Good morning. Today I'd like to talk about 4 news items that passed my Google feed alert system in the last couple of weeks from the 12th of September to the end of September. The 4 items include who owns imported donor sperm, the cost of IVF medication, concerns in the Indian IVF industry, and a new tool that aims to predict the likelihood of embryos developing diseases. By ways of introduction and welcome, I'm not a medical practitioner and this is not medical advice, but hopefully the videos will help you ask questions about your treatment with your doctor and maybe understand the advice you receive. I'm just starting out, but if you'd like to, please click subscribe to be notified of new videos. But whatever you do, make a comment and press like. And if you'd like to support me, go to my GoFundMe page and support me. Okay, one quick word from my sponsor. My sponsor is FerdAid. FerdAid is the primary source for this channel. It's an online EQA program in andrology and embryology. And clients that use that have the knowledge that their staff are under constant review and assessment for embryo grading and sperm grading, and this should give immense comfort to their clients. It runs schemes in concentration, motility, morphology, DNA fragmentation, vitality, a wide range of embryology schemes. You can enroll as a trainee or as a professional. You can subscribe as a small clinic or a large clinic, and it can be used for training or competency or accreditation. It's a fantastic scheme, but then I wrote it myself, so I'm biased. Okay, the first article. New South Wales woman blasts Monash IVF clinic for holding her future child hostage. This is about who owns imported sperm, the client or the clinic. As I understand it from reading the article, which appeared in news.com.au, a client imported sperm from a US sperm bank into Australia, had a child using that sperm, and then wished to move to another clinic. The original clinic then allowed the movement of embryos, of course, but refused to move the donated sperm on the grounds it was going to lose control of the number of children that could be conceived by that donor. Now, certainly the clinics that run their own donor program have complete control of all the allocations of that sperm, and they are only able to limit sperm to 4, 5 or 6 couples that have had a baby. But once the sperm is moved to another program, they lose control of it, and therefore, is there anyone taking responsibility for how many children that might be conceived with the donor? The problem I have here is that I don't really know what the rules are for children born to international donors. And secondly, if the client has purchased the sperm for herself, she's unlikely to allow another clinic to use it. And if they do, they would then have control of the number of sperm. So I think this is a difficult situation, and I suspect the woman's probably got a case to answer. The second article is about the cost of medications in India. Sorry, go off the sidetrack. Cost of medication over the last 10 years. This is a note from drugtopics.com.au. The cost of in vitro fertilisation medication has surged by 84% over the past 10 years, far exceeding the 37% actual average price rise for most pharmaceuticals, according to new data from GoodRx List Price Index, whatever that is. This rise adds to an already expensive treatment, making therapy increasingly prohibitive. Several factors contribute to the high cost of IV medications. As biologics, they are complex and expensive to manufacture, and as patented brand name drugs, patients have limited access to more affordable generic alternatives. So the article is saying to address these challenges and improve access to IVF treatments, advocates have called for increased public funding and stronger legislative support. Because one option is to use fewer drugs. Now, in countries like Australia and Israel that support the cost of medication, this is not an issue because the government just pays for whatever the doctor prescribes. But the cost to the community is huge. But for where clients are having to buy their own drugs, They then are compromised between how many cycles of treatment they can have and paying for the medication. Couples normally only have a set amount of money to spend on IVF. If most of it is spent on drugs, that means they have fewer attempts. So maybe using fewer drugs, something clients could discuss is whether the clinic is interested in natural cycle IVF or low dose IVF, or ask their doctor to justify why they're using such high doses of drugs and therefore a higher cost. The third one that worried me a little bit was published in BMJ and was talking about India's roaring IVF trade struggling with malpractice. Now, I don't know anything about the Indian IVF industry. I know there are lots of really ethical and absolutely excellent programs. But with an IVF market projected to be about $3.7 billion over the next 5 years, some Indian doctors are worried that an absence of strict monitoring is allowing unethical practices to flourish. So in countries like Australia and the UK, the management of each cycle is very strictly legislated and regulated, and there is almost no unethical behaviour occurring in these countries that we're aware of. Now, I don't know the situation in India, but according to the article, it performs somewhere about 200,000 to 250,000 cycles a year and hopes to reach over 500, 600. That's an amazing number of cycles in the next 5 to 10 years. With demand growing, big hospital chains like the Nova IVF, etc., are opening new centres all the time, even in smaller cities. Other investigations have uncovered trafficking networks linked to IVF centres, with babies being bought from surrogate mothers and sold to organised crime. I have no idea, but it worries me a little bit. The real concern would be that there is always pressure to find eggs for women with poor ovarian reserve, and the real concern that has happened in America in the mid-1980s is that couples only told they've collected, say, 10 eggs when they have collected 15, and the other 5 are given away as donated oocytes, but the original client doesn't know that. That would be the major concern I would have with something like this. But it does go to show that IVF in some things have taken off at such a rapid rate that, in fact, it takes a long time for the legislation to catch up with monitoring the programs. And India would send their best interest and reputation to do that as soon as possible. And the last one is what I'm really concerned about. This was published in the College Fix, which I think is a Boston University website. Dystopian society, academics develop a tool to help IVF patients decide which embryos to destroy. Now, I had to reproduce here the takeaway comments from the article because it said here, this summary's takeaway was generated by artificial intelligence, talking about how artificial intelligence is going to tell couples which embryos to destroy. But I'd like people to know that this takeaway is being read by JAMES, which is not AI. Okay. Enough of this silliness. The new tool aims to predict the likelihood of embryos developing disease like Alzheimer's, raising ethical concerns because of its role in embryo destruction during IVF. Jonathan Nomley, co-founder of Heresight, defends the tool, arguing that it empowers parents to make informed choices, despite criticism linking the technology to dystopian outcomes. The bioethicist, Dr. Aaron Kearty, argues that such genetic testing could lead to discriminatory practices and the commodification of IVF of human life, emphasising that it merely discards embryo rather than treating genetic conditions. And I have to say, going through their websites, if you want to read something like this, embryos inherit different genetic parts for each of their parents' genomes. This leads to genetic variation. This variation gives rise to differences in genetic risk for diseases, some of which we can capture in our polygenic scores. And then, given information about the prospective parents' ancestry and disease status, we can simulate sets of embryos with realistic genetic variation and identify those at the highest, lowest, and average genetic risk. This tool helps prospective parents understand how well our predictors can stratify risks of disease amongst their embryos. Oh, sounds rather nice, doesn't it, if you can understand it? And then someone from the clinic posted on X an example of this. And I have to say, so they were promoting that program outperformed all the others. So what worried me here was we came out of stealth with a paper showing our predictors for 70 diseases validated within family beat the competition with improved performance in non-Europeans. So one gets the impression there is immense competition between these genetic testing authorities, and I don't know that's good. The second thing that worried me was how could you possibly choose embryos where they're being assessed for prostate cancer, breast cancer, basal cell carcinoma, testicular cancer, melanoma, type 2 diabetes, hypertension, gout, Alzheimer's disease, and inflammatory bowel disease? And every embryo will have a relative risk of it, some more than others, but every embryo will have a potential risk. And how can anyone, even if geneticists make sense of that, how can you possibly weigh embryo, which embryo to put back based on relative risk? And the third thing that worries me about it is that the author here was comparing three methods, their new program, genetic prediction, and one called ORCID, which I don't know what it is. It's very irrelevant. But they are pointing about how good their technology is. What worries me is how bad the other ones are. So even if you're making a selection on an embryo based on genetic risk, depending on which program you're using, you're all over the shop. In fact, it's quite scary. Okay, so now I have to say right from the outset, that I'm not against polygenic testing of embryos. I can see a case for a family history of breast cancer or prostate cancer where the client wishes to remove this familiar risk from their family tree. And they may be prepared to put back poorer quality embryos or not have a baby just to ensure that their children do not have the same risk that they have. The problem I have with the widespread polygenic testing is that all the embryos will have some poor traits. How does a couple even try to understand the risk data? Because I certainly struggle with it. Couples will have to choose between embryo quality and pregnancy and trying to pick the child with the genetic traits, even though the chance of pregnancy may be less. It's almost like a Sophie's choice. And anyway, most women do not have enough euploid embryos even to consider testing for their traits. And there is not enough genetic counsellors to meet them. There was a big point on LinkedIn just recently about the lack of genetic counsellors. And I'd also make the point that IVF is already so busy. They do not want to have new fertile clients competing with scarce resources just to try and create embryos which have a lower certain risk. And the other thing, of course, is they won't be testing for this, they'll be testing for other traits as well. So polygenic testing sounds like a really good idea, but clinics need, I think, to get this under control very early on about how it's applied, rather than letting the genetic industry run wild with testing embryos. It's going to create a havoc in IVF clinics. Well, I hope you've enjoyed my little roundup for the week. I always finish by saying IVF is a personal journey that involves the actions of many, many techniques and staff, and helps to understand all aspects of that journey. I hope this information be of value. If you like the information provided, please tell other clients about this service and please subscribe. Okay, thank you.